Welcome to A Real Affliction, BPD, Culture, and Stigma, a podcast devoted to exploring how we experience, treat, write about, advocate for, and conceptualize borderline personality disorder. My name is Cynthia Gralla. I'm a writer and teacher with a history of BPD. Trigger warning, this episode will talk about suicide. Dr. Sara Masland made me cry. Last year, I found her article, Destigmatizing Borderline Personality Disorder, a call to action for psychological science, while doing research for the book I'm writing. Her article focuses on how research, editorial, and publishing processes may inflame stigma against BPD. She and her co-authors wrote it in response to a truly revolting peer-reviewed study titled Testing the Hot Crazy Matrix, Borderline Personality Traits in Attractive Women and Wealthy Low Attractive Men Are Relatively Favored by the Opposite Sex. That's a real title. In an article responding to Testing the Hot Crazy Matrix, Thomas M. Olino and his co-authors wrote, "The crazy in the title of this paper refers to borderline personality disorder. We would have thought this would go without saying, but this kind of language should be avoided by all and certainly has no place in scientific writing. It is especially saddening to see it used as a means of generating interest in a publication." Although the authors revised the title, the use of BPD symptoms to operationally define the concept of crazy remains central to the manuscript. Thus, this work reflects not a harmless use of stigmatizing language, but perpetuates multiple harmful and stigmatizing biases towards individuals with BPD and others with lived experience of mental health symptoms. Dr. Masland and her co-authors went even further, writing the Destigmatizing Borderline Personality Disorder article and providing in it a list of recommendations for how psychological research should be conducted, written, and published to protect those with BPD, such as taking care with wording in titles and abstracts, which are all that many readers see, and involving people with BPD in the construction of guidelines for non-stigmatizing language for academic journals. This article made me cry because I was so used to facing the headwinds of stigma whenever I tried to solicit help from healthcare professionals. It was proof that some researchers and therapists fervently believed that people with BPD are as deserving of care as people with any other mental disorder. It made me feel seen and validated. It made me feel hopeful. Dr. Masland is a Harvard-educated clinical scientist and a licensed clinical psychologist. She has won multiple awards for her teaching at Pomona College, a liberal arts college in California, where she is associate professor of psychological science. Her research explores such topics as BPD, stigma, and epistemic trust. She is also a trainer in good psychiatric management, a generalist treatment approach for BPD, created around 10 years ago by John Gunderson, who was a director of the Borderline Center at McLean Hospital, where Susanna Kaysen was institutionalized in Girl Interrupted. Why is a generalist approach to BPD treatment necessary? After all, there are great specialized treatments for BPD, including dialectical behavior therapy, which Jessie Shepard advised everyone to do in an earlier episode on her children's book about BPD. And personally, I've always wanted to try mentalization-based therapy, another evidence-based treatment. People with BPD display a diminished ability to mentalize emotional states without making assumptions about other people's thoughts. No thanks to our hyperactive amygdala, which causes us to overreact to stimuli like facial expressions, and our underactive prefrontal cortex, which fails to calm us down. Mentalization-based therapy could help me with this challenge, but there's no one trained in it in my area. Many people with BPD have likely felt the same frustration of knowing that an evidence-based therapy would help them, but being unable to take advantage of it. Evan Iliakis, one of Dr. Masland's students, analyzed the ratio of treatment-seeking BPD patients to clinicians certified in one of the evidence-based treatments for BPD across 22 countries. He found that in the United States, there are 5,933 BPD patients seeking treatment to every one specialized clinician. In Canada, that rate is 9,339 to 1. Nearly 10,000 treatment-seeking individuals for every certified evidence-based treatment provider. Clearly, specialized treatment providers for BPD are overwhelmed. With good psychiatric management, Dr. Masland hopes to significantly expand treatment opportunities and reduce clinician stigma during the training for it. The existing evidence-based treatments are very expensive, both in terms of the clinician's training and patient's treatment. In contrast, good psychiatric management maximizes skills that therapists already have, and the results so far are very promising. In all of her roles, Dr. Masland is trailblazing a path to more accessible and compassionate care. In this first part of our conversation, she'll explain the history of the BPD diagnosis, the origins of its stigma, and why good psychiatric management is a necessary addition to the roster of treatments for a disorder that affects millions. Sara, thank you so much for coming today. I wanted to start off by asking you to give a little description of your research focus.
Sure. So my research, I actually wouldn't say that I have one strict focus.
Right. Focuses would be better.
Yes, of course. Yeah. I'm at a liberal arts college, so I get to kind of do what I feel good about.
Yes.
Which is really nice. And I would say that, in terms of borderline personality disorder, I would consider that disorder as my main focus in a lot of ways. But within that umbrella, I am really interested in increasing treatment accessibility for folks with BPD. And I do that through work with good psychiatric management. And this is a treatment that I hope we can talk maybe more about at some point. But
definitely.
Good. But this is a treatment, it's a generalist treatment, and I'm interested in understanding all kinds of things about it in terms of how to make it more accessible to folks. Also, how training in good psychiatric management might help us destigmatize BPD amongst mental health professionals.
Right.
So that's one area of my research. Another is understanding aspects of BPD that have to do with social, cognitive, affective processing. So I'm really interested, for example, in trust in BPD.
Yes, I saw that in your articles. Yeah, really interesting focus.
So this actually goes back to my dissertation work, and I'm interested in how people with BPD form trusting relationships, how they process whether someone else is trustworthy. But I'm also interested in this concept of epistemic trust, which arose out of the developmental psychology literature, and it's also part now of mentalizing based therapy. And epistemic trust has to do with how we kind of understand knowledge as being useful for us, right? So when we learn something, how do we trust that what someone is teaching us or what we're getting from an experience is actually really relevant to our own operation in the world?
Right.
How do we kind of internalize that information? So I would say those are two foci, so GPM, and then trust and epistemic trust, and then also stigma, which is also, I think, just a part of anything that I do these days is thinking about how can we think about research that increases our understanding of BPD in a way that destigmatizes the disorder. And some of my research measures stigma, right? I look at stigma specifically, but even when I'm doing any other kind of research, I'm thinking about, how am I approaching this in a way that might engender stigma or destigmatize?
Yes, it's such a fascinating question. And I love what you said about being positioned at a liberal arts college, possibly enabling a multifaceted approach to things. I went to a liberal arts college, Amherst, for my undergrad, and it did seem like so many of the professors there kind of were allowed this sort of wider berth. And I think that really helps to see things that often go unseen. And yes, one of the things I really like about interviewing people is it gives me an excuse to do a deep dive into their work. And so I certainly haven't read all of your articles, but I read a dozen or so last week and several of the trust ones. And it really made me think about my own relationship to trust. and how it intersects with BPD for me and my childhood history. And I think I'd always felt, well, it's good not to trust people because you can be hurt. At least I'm aware I'm protecting myself. And of course, it's not with everyone. It's not with my partner or my friends or most of the time, but you're just reading your articles made me think about that more, and that this may be a part of the way my brain functions, and it may not be in my history, and it may not be ideal. So that was really an interesting aspect of your research for me.
As I've researched borderline personality disorder, there have been lots of surprises. And I think one academic surprise has been just how fragmented the field feels in some way. And this is true both in the research landscape and also the clinical space. I think they are reflections of one another. It seems like people approach BPD from very different perspectives. You have the psychodynamic folks in one camp. You have folks who approach BPD from a more kind of cognitive behavioral camp and maybe supportive of DBT. And they have a very different clinical approach than the psychodynamic folks. What I see is this kind of lack of integration that I haven't seen quite as significantly, maybe, in other areas of research. And fortunately, I think this is something that is changing. In the last 5 years, the landscape has certainly changed to one more of collaboration. And I think that as we actually do start to integrate these different lenses or perspectives, we are actually going to start to have better progress. I think of the parable of the blind men and the elephant, where, if one person is touching the tusk of the elephant, they think it's, a sword. If they're touching the tail, they think it's, a snake. But we really need all of those perspectives to understand the holistic view.
Yeah. Do you think that the history of BPD being very stigmatized, does that possibly play into this fragmentation of the researchers? Maybe people feel like they have to get deeply entrenched in their focus, their understanding of BPD to sort of push back against the stigma. I don't know. I was just wondering.
That's an interesting question. I hadn't thought about it from that perspective. But I think that does make sense. I think there's a way that the stigma that has surrounded BPD, I think first and foremost, we should never try to overshadow how much that affects people with BPD. But there's also this kind of stigma by proxy that affects researchers. And I will point out that many researchers and clinicians do themselves have lived experience. I hope that we get to hear more of those stories as the years progress here. But I do think that there's a way that when you are in this space, people judge you. Other researchers or other clinicians judge you. Why would you do that? You must also have BPD. What does this say about you? Research is me search. And I think that may, in some cases, cause people to really dig in their heels, in a number of different ways. And maybe that is one way where they really get kind of more entrenched in their theoretical perspective as a way to kind of guard themselves against those stigmatizing ideas. I hadn't thought about it that way, but it makes some sense.
Yeah, and I don't know if my supposition was correct, but just I had read what you said in one article about the denigration of me search, which was kind of shocking to me because for me as a person with BPD and with some other diagnoses, I think it's great if someone with lived experience is looking at it. It doesn't mean you have to have that, but I think to most people who are trying to cope with a disorder, that is no problem. And it just goes back to all the stigma about BPD. And to kind of get a better handle on that, I was wondering if you could talk about the history of the BPD diagnosis.
Sure. So I think the first thing to understand with the history is that the word borderline was used long before we had a clear set of diagnostic criteria for what we now call borderline personality disorder. Borderline personality disorder first entered the Diagnostic and Statistical Manual of the DSM in 1980, which it still feels very recent.
Yeah, absolutely. Especially because a lot of people, if they've read anything about it at all or seen anything, it might be Girl Interrupted by Susanna Kaysen. And she was given that a diagnosis of it. And that was in the late 1960s. So I knew it dated back that far, but it actually goes further, I believe.
Yeah, so the term borderline has been used at least since, I would say, the turn of the 20th century. It's an old term, and it first became borderline personality disorder after John Gunderson and some others did some work to actually try to kind of think about, like, how are we using that term and what criteria might we actually apply in a systematic way. And that work happened in the 1970s, and then we saw, DSM-3 incorporate BPD. But the term borderline, it's been used for much longer, and it's a psychodynamic term. It's been used in a number of different ways. The way that I think about it most simply is that it's really meant to identify people whose difficulties live at the border of psychosis and neurosis. That, however, is not the primary conceptualization of BPD today. Right. So it's tricky because that term has existed for a very long time, but it doesn't necessarily connect to how we talk about BPD with our patients in research, how we use it to understand difficulties. So the term is tricky in that way. The other way that term is tricky is that before we had a clear kind of conceptualization of what we were talking about and how we were using the term, it definitely was used pejoratively. So it was applied to people who were primarily women, and who were labeled as difficult or unable to be treated, treatment resistant, all of these terms, manipulative, hysterical, attention seeking, all of these terms kind of got lumped together with someone who might be described as borderline. And certainly some of those people to whom that term was applied would meet diagnostic criteria for BPD, but certainly some of them wouldn't. So there wasn't a very systematic way that term was used. And I think that the way that it got applied to these other labels, which are pejorative, it was really born of this kind of lack of understanding, but also, I would say, a fear reaction. And you can actually see this, and John Gunderson did some interviews where he actually talked about his own fear reaction, right? Here's a group of patients that their difficulties are hard to understand at this point in time, and they seem at very high risk, right? We have these high incidents of suicide. We see self-harming behaviors. And for a clinician who's not prepared, right, who doesn't have an understanding and a set of tools to help these people, that can feel scary for a number of different reasons. And I think that's part of why sometimes people react to that kind of fear in a way that is really counter to how they actually would like to be operating in their clinical practice, right? They actually end up harming people through pejorative language and treatment. I've kind of veered a little bit off the path there, but
I'm so interested in your perspective on the diagnosis. And we were talking a little bit about hysteria before we started the interview. And it does seem that as hysteria is kind of decreasing in popularity as a diagnosis, is there any link between that and the rise of the BPD diagnosis? Does science always need this sort of category for people who are difficult to treat, and especially women?
I like to think that we're not, or we're at least moving away from using the category in that way. So I do think maybe in those early days, there was a way that they were linked. But I think you've got to also look at, what does the diagnosis get you? And the diagnosis of hysteria, the treatment for that would have been get pregnant again. Right.
Yeah.
Let's get your womb. Let's make it stop wandering.
Yep. Yeah. Wandering around your body.
Yeah. Yes. Right. There's so much that could be said about that. But, the BPD diagnosis, I think now really is an entry point to a hopeful clinical experience if you are working with clinicians who have, some understanding. So it's an entry point to effective treatments.
Right.
It's an entry point to understanding how you can get on a road to recovery. So most psychiatric diagnoses can be misapplied in a number of different ways. I think that BPD, we often think about it in that context because of this history.
Right.
I think that, historically that term borderline did have problems. I think now, though, that we now use the BPD diagnosis as a way to understand people, and in a way that I think is ultimately destigmatizing when we're using it in a helpful way. I think that, for example, getting the diagnosis, if it's delivered in the right way, can lead to a sense of understanding for people that combats self-stigma. I think that if we can work on some clinician training issues, perhaps in the field, that the diagnosis could also help decrease stigma across the board amongst clinicians. So I'm a proponent of the diagnosis.
And you did a really interesting study where you were looking at person first language and versus giving a vignette about the actions of a certain person to the study participants, and you were seeing how they reacted when you said this was a person with BPD, or was it a borderline? And then in one vignette you didn't give any diagnosis, and that was the one, contrary to your expectations, that seemed to provoke the most hostile reaction. The implication being that as problematic as the diagnosis has been over time, it seems better to have it because then people understand why this person is acting the way they are. And that was really interesting to me too, and kind of hopeful. Because that's what a diagnosis is supposed to be. It's supposed to be a context for people's behaviors and for understanding how to cope with them, cope with that person, and for how that person can cope with themselves. So I don't know if I misrepresented that study in any way. So
I think that was a beautiful summary of the research. And it does actually speak to one surprise within my research experience, which is that I was expecting when we call people borderlines, for that to be the condition that engendered the most stigma. But actually, as you said, it seems that giving a label, any label, might actually help us understand behavior and context.
Absolutely. I have one more question about stigma specifically before we move on to talking about good psychiatric management, which is so exciting. My final question is that despite all that the field has learned about BPD over the past couple of decades, the suicide rate doesn't seem to be decreasing. Does stigma play a role in that? Or I'm sure there are many, many things that are at play, but I was wondering what your feeling was about that.
The research for me says that's a great research question that we should study, right? The clinician in me says yes, absolutely. Even without data, I would stand, on a soapbox and shout that out loud, right? That decreasing stigma would also decrease suicide rates. I think there's good evidence for that in a number of different ways, but I think that it probably happens indirectly and directly. When there's stigma, people internalize that. And it makes them feel like they have less of a sense of belonging in society and they have more negative views about themselves. These are things that we know, given, for example, the interpersonal model of suicide, are going to lead to higher suicide rates. There's also ways that stigma creates significant barriers to care. People are not getting the treatment they need. And, that's also going to impact suicide rates. So absolutely, yes.
Another thing I saw really clearly in looking at your research is that if people with BPD can just hang on and survive through the most difficult periods, they have a really good prognosis. And there are now a number of different treatment options. But like you said, sometimes there are barriers to care because clinicians maybe it's even just that they're nervous about being able to handle a patient with BPD because they don't feel completely comfortable, or they know it might be really challenging for them. That's something that took me years to find some empathy with, but I think I can see that would be really scary, or they might be scared of losing a patient to suicide. So that's one barrier, but there are other ones too with the long-standing evidence-based treatments like dialectical behavior therapy, because they're very time intensive. They're expensive to train in. They're often expensive to do. I've always wanted to try mentalization based therapy because I think it would really help me with some of the things I struggle with. Every partner I've ever had says things like, "You're putting words in my mouth," and I don't mean to. It's just really hard for me to understand anything apart from their basic feelings, like what they're actually thinking or where they're coming from. I can really struggle with in acute moments, but I don't think there's anyone near me who does it. So can you maybe give a brief overview about how BPD has been treated and then tell us about good psychiatric management or GPM.
So I think that oftentimes when people think about treatment for BPD, the treatment that first comes to mind is dialectical behavior therapy.
Yeah.
With good reason. I think that there's great evidence for DBT being effective.
Yeah.
And I love, that it was also developed by someone, Marsha Linehan, who herself has lived experience of BPD.
Absolutely.
It's definitely a fantastic treatment. So there's DBT. There's also other treatments, specialized treatments for BPD that can be harder to find. So you mentioned mentalization-based therapy. There's also transference-focused psychotherapy. There's a few others like cognitive analytical therapy, a few others that are maybe less well known.
Right.
And these are very specialized treatments. So as you mentioned, they require a tremendous amount of training. They're hard to access both for clinicians in terms of getting that training, but also for patients in terms of finding clinicians who are taking patients.
Right.
A former student of mine wrote a paper somewhat recently looking at the ratio of treatment-seeking people with BPD to the number of clinicians who are trained in a specialized treatment. And he looked at this across a number of different nations. And I don't want to get the numbers wrong, but I think in the United States, it was something like there are 6,000 people with BPD seeking treatment. And these are just the people seeking treatment. There's many others without BPD not seeking treatment. But 6,000 seeking treatment for every one clinician who's trained in a specialized treatment for BPD. So obviously the demand just far out surpasses the supply of treatment. That's a big problem. And I think we need to be thinking about other ways to deliver care. And those treatments are fantastic. But they're also, you've got to also realize, even if you can get access to those treatments, some of them are extremely expensive and time intensive, as you said. Mm-hmm. So there's some problems with just the provision of care generally.
Did you develop GPM yourself?
No. So good psychiatric management was developed by John Gunderson. And there was some debate about whether, I think he debated with others, whether it should be called good psychiatric management or general psychiatric management.
Right.
But both those words mean something in that it's good psychiatric management because, these are the principles of treatment that are good enough, right, for helping the majority of people with BPD. There might be some people for whom a specialized treatment is necessary, but these are the principles that are at least good enough to help most people. The term general is also important because it's a generalist treatment that is meant to help clinicians who already have training. They can learn it pretty quickly. They don't need to be extremely specialized. It doesn't require the thousands of dollars of training or the many hours.
Right.
It assumes that people with good clinical skills can learn the treatment pretty quickly. And when John first kind of released this treatment, there were a whole number of different trainings that were done for free to help get people kind of trained up. So it's a very different model. It's not a profit-driven model, and it's meant to increase accessibility, right? This is a generalist treatment most clinicians can learn. Let's get this into the toolbox of as many clinicians as possible so that they can be helping as many patients as possible with the principles that we know are going to be good enough for most people. And then we can envision integrating that into systems of care where maybe there's a stepped treatment approach. Maybe if GPM isn't enough, then we can think about, then maybe someone should be trying MBT or DBT. Or maybe someone is in DBT and they're doing great and they can step down to a treatment that's less intensive, right? But they still have that support. So there's ways that we could be thinking about, going back to your very first question and my response about fragmentation. There's ways we can think about in the clinical arena, actually really integrating these different types of care to ensure that we're meeting everybody's needs the best that we can. That's my hope. And I think that that's what John Gunderson wanted as well. He wanted to be helping as many people as.
Yeah, it makes sense. I mean, I knew it had to be a really high ratio, but 6,000 to 1, obviously we need things that are more widely accessible. How would someone access GPM if they were interested in trying that? Do you have a list of therapists who have trained in it?
Yeah, so there's at McLean Hospital, where John Gunderson, spent most of his career. There's the Gunderson Personality Disorders Institute, the GPDI, and I believe they maintain a list of clinicians. And they also have a list of the trainers in GPM so that is accessible. I think, we're still not where we need to be. GPM is not actually that old. I think that the kind of seminal book was written in 2014. So it's been around for just about 10 years. And for us to make real traction in numbers, it's going to take more time. But it is available in many places now, fortunately, and around the world too. It's a global initiative.
And you've also studied how trainee stigma against BPD has decreased even during one-day trainings. I read an article about that. So that was really hopeful news as well. Yeah.
Yeah. So there's a few articles that show a very similar effect there, where when we teach clinicians about BPD, they have less stigmatizing attitudes about people with BPD, which makes good sense. The problem is actually that clinical training programs kind of across the board, if you look at PhDs, PsyDs, master's programs, psychiatry programs, most of them do not have explicit training for BPD. And that's a big problem because we know that many people in clinical settings have BPD.
Please come back on July 1st for the second half of this interview with Dr. Sara Masland. I want to thank Dr. Masland for her time and her much needed work, and thank you so much for listening. Take care.